Thank you so much, Dr. Matthew John, for having me for this event. I think it's a wonderful event. And today I'm going to talk about a very interesting topic, that is sarcopenia in people with diabetes, the risk factors, the assessment, and the prevention. So here you can see three people, right? The one on the left, an elderly gentleman. The one in the middle probably, goes to the gym quite often. You can see a photo of the gym in the back. That's the best gym I get, that is mental gym. And the third one you see, who is probably, me, who is probably having sarcopenic obesity. So from here, it's very clear that, the one in the middle is probably the one who is clearly the most healthier. But our patients don't look like this all the time, right? The patients actually look like this. So this is a famous YY paradox by Dr. Yudkin and Dr. Yajnik. And you can see both the people have, both the gentlemen have similar age, similar BMI, yet it's, difficult to say that which of these is having, a sarcopenia, which of these is probably the healthier one. So our patients often look like this. And to me and you, the patient may be the, the fittest person in the room, for me especially, but, if you look more carefully, you might be actually sometimes wrong. So what exactly is sarcopenia? And as Sir described to us, sarcopenia is basically two major things. One is the loss of muscle mass, but more importantly, the reduced function of the muscle. So if you see a more formal definition of sarcopenia, and this is given by the European Working Group, they say that if one of the three criteria, that is loss of muscle strength, loss of muscle quantity, or low physical performance, if this is one of the three is there, you should consider sarcopenia. But of course, if all three are there, you should consider a severe form of sarcopenia. So that is basically an operational definition of sarcopenia. So how do you diagnose sarcopenia? How do you make the diagnosis? And there are two things which I want you to take home from this lecture. One is obviously to use your gym more often and probably increase your muscle mass. But the second one, which is more important for a clinician, is to actually diagnose sarcopenia, because we see patients in our clinic and we often we see their blood sugars, we see their vitamin D reports, but we fail to see the clinical side of it, and that is the patient in front of us is sarcopenic, and perhaps we need to assess that problem as well, especially when we are dealing with an elderly population who are prone to these problems. So how do you diagnose sarcopenia? Contrary to belief, it is very simple to diagnose sarcopenia. It just takes 30 seconds to do it. So if you see the European guidelines, they give you a simple mnemonic, that is FACS, that is find the cases, assess them, confirm them, and assess the severity of the cases. So, and this is, if you want to find a case, and when I joined, Dr. Kalra was giving his wonderful deliberation, and he talked about simple screening questionnaires. And, this is a simple screening questionnaire, which is, known as SARCF, which can be used, by an assistant. You can just ask an assistant to fill it up when the patient is waiting in the waiting room. And then here you can see, a simple score of 4 or greater is predictive of sarcopenia. And here we look at the strength, assistance in walking, rise from the chair, climb stairs, and falls. And you just, all you need to do is, you need to just assess the patient, ask them a few questions. And this is a simple screening questionnaire for diagnosis of, finding the cases of sarcopenia. To assess for sarcopenia, again, not very difficult. You can use two simple things. One is chair strength test, another is known as a grip strength. A chair strength test is very simple to perform. I'll just show you the quick slide of it. You take a timer. We all have a digital timer these days. You don't need to see this, so all you do is put a 30-second timer and ask the patient to stand up and down on a chair as quickly as possible, as frequently as they can, right? So it's a simple test. The patient has to use, all the patient has to do is to use their lower body strength to get up and get down. Like I said, it takes just 30 seconds to make the diagnosis. The cutoff for this is 12. So if you can, and try doing this, if you're sitting there listening to this lecture, try doing this in 30 seconds. And, at the end of the lecture, put it in the chat or tell me how many times you could stand, or whether you suffer from sarcopenia or not. And, the cutoff is, you can see the cutoffs depend on the age, of course, but, generally speaking, less than 12 is considered to be abnormal, right? In a typically median score would be less, if it's less than 12, you should consider that to be abnormal. So again, like I said, if you're sitting in the chair, get up, do it, and tell me how much it is. You can use slightly more, sort of a equipment if you want. This is a JAMA dynamometer. These are available on Amazon. You can buy it. It's not very costly. This tests the grip strength. You can use it especially for if you're trying to understand, do clinical studies on sarcopenia. This is a very useful device. And this is known as Camry's dynamometer. Often a digital dynamometer, you will be able to purchase this very cheap devices, cost less than $1,000 easily on Amazon, and you can use this very easily. It takes again 20 seconds to really make the assessment. So a grip strength typically is considered less than 28 kgs for men is considered to be low, and less than 18 kgs for women. So when you say kg, this is what the values which will be displayed in this dynamometers. And if it's less than 28 for men and less than 18 for women, it is generally considered to be on the lower side. Okay, how do you confirm sarcopenia? Again, if you've gone and done so much, I think you've done great. If you're just screened for them, and if you're really, done the chair strength test, I think that is more than enough. But if you want to go a little deeper and really want to look at the patient in more detail, you can do a confirmation of the same by checking the, detection of the low muscle quantity and quality. For this, of course, the standard and the gold standard is a DEXA scan. So if you're sending your patient for a BMD, for bone mineral density using DEXA, you can also ask your DEXA technician. It's a simple software. It doesn't require anything very fancy. You can use the same for body composition analysis also. You can of course use CT scan or MRI for research purposes. A very simple thing to do is, this is done by oncologists, that if you're doing CT abdomen, try to look at the muscle mass at L4 level. This is a kind of a standard. You can check a lot of studies on that done on this, and the muscle mass at that level is considered to be a simple detector of that. So like you don't need a special CT just for this. You can use one of the CT scans done recently for this. Of course, you have bioimpedance devices which are very popular, used by a lot of gym people, but it is not advised to use it in general because it is not very accurate. But I think DEXA is something very simple. So if you're using DEXA, of course, you need something for body composition analysis. This is a report generated from Hologic, and you can see it will give you the lean mass, which is the one mentioned here. The total lean mass in this patient is 59 kgs. Now, of course, it's simple to understand the fact that a person who is larger in size will have more lean mass. So what you do is you need to take the lean mass and divide by height square. Right, so you need to take the lean mass, which is derived from the DEXA, and divided by height square. And in Asians, this is what is important to us. Sarcopenia is defined when this value is less than 7 kg per meter square in men and 5.4 kg per meter square in women. So it's a very simple thing to do. Again, not very complicated. Like I said, if you're treating osteoporosis routinely and you're sending your patients for a DEXA BMD, also ask them to measure the body composition also. And severity can be done, checked very simply by doing a simple gait speed, choose a distance of 6 meters and calculate this velocity of the patient. And, if it's less than 1 meters per second, you have, a highly severe, and like, if you're smart enough and if you're like Sherlock Holmes, as soon as the patient walks in, you can probably say, look, this guy has sarcopenia. The slow gait speed is one of the markers of, not only it's a marker of sarcopenia, it's a marker of severe sarcopenia. So just keep your eyes and ears open for your patient. So just to summarize the diagnostic part of it, this is the current definition of sarcopenia, based on the various guidelines you can see here. And I'll not go into details because I already discussed this, but you can of course look this up, and you can probably take a screenshot of this and save it and paste it on your clinic for making a quick diagnosis. So what are the risk factors for sarcopenia? Why does sarcopenia develop? Of course, age is the biggest risk factor, vitamin D deficiency, obesity, and I'll talk about this in a few minutes, diabetes, deficiency of sex steroids, other endocrine disorders like thyrotoxicosis, Cushing's, malnutrition, very common in India, certain medications, and neurodegenerative disorders. So then let's come to the concept of sarcopenia and obesity. So what exactly is sarcopenic obesity? Now, there is no formal definition for sarcopenic obesity. It is basically low muscle mass with increased fat mass. So again, a simple way of testing this is looking at your DEXA body composition report. Now, the important point here is that sarcopenia and obesity have a bidirectional link. So sarcopenia leads to obesity, obesity leads to sarcopenia. Again, I'll not go into too much details of it, but remember, obesity is a form of sort of a mild pro-inflammatory state, and this pro-inflammatory state leads to depletion of the skeletal muscle, leading to a sort of a bidirectional link. And reduced skeletal muscle again reduces the overall function, increases insulin resistance, and often worsens the obesity. So, like I said, there is a bidirectional link between obesity and sarcopenia. Again, looking at sarcopenia and diabetes mellitus, right? So basically, sarcopenia, what sarcopenia does is it produces peripheral insulin resistance. Remember, muscle mass is responsible for your glucose disposal, that is diabetes 101. So in absence of muscle mass, the glucose disposal is naturally reduced. It is simple to understand, and this leads to peripheral insulin resistance, which may of course lead to diabetes. And recently we had Dr. V. Mohan publish the various cohorts of patient or various clusters of patient with diabetes, where he talked about mild diabetes in elderly, and which is one of the cohort or one of the cluster. And I think a lot of the times the cluster in Indian patients is simply because of sarcopenia. It's just sarcopenia that leads to simple mild form of diabetes mellitus. How does diabetes itself cause sarcopenia? Diabetes again is a state of low grade inflammation. There is reduced physical performance, and of course certain medications that we use may have an impact on causing sarcopenia. Now, as far as the medicines are concerned, there are two of them which are likely to produce sarcopenia. One is metformin, and the other one is SGLT2 inhibitors. We'll discuss SGLT2 in a minute here. But insulin, remember, and perhaps sulfonylurea, we're not very clear about it, but insulin definitely increases the muscle mass. That insulin is anabolic in nature, and it increases the muscle mass, and hence, it has a positive impact as far as sarcopenia is concerned. So, you have a poor controlled diabetic with sarcopenic obesity. Giving insulin may cause weight gain, but there is also increase in muscle mass, which is the interesting aspect of using insulin. Again, you can see from this table, most of the things, we are not very clear because there are not many studies done in medications, impact of medication on sarcopenia. And I think, if you're young doctors listening to this, please, I request you, this is an area of research which you should strongly consider, because, we have an aging population and Indians are often having sarcopenia already. And I think using the right anti-diabetic medication for these population may be very, very useful. And I think this is a study which must be carried out. It's a very simple study and can be done very easily. Talking about SGLT2 inhibitors, and this is one of the criticism. Now, SGLT2 inhibitors, as you heard from Dr. Neeta Deshpande's talk, a wonderful talk, she said SGLT2 inhibitors increase the survival of the patient, and this is no doubt about it. But one of the criticisms of SGLT2, especially from our patients, is that they often lose significant amount of weight, and they also develop sarcopenia. Now, it's easy to understand why sarcopenia develops with SGLT2. Of course, there is a low insulin, high glucagon, which increases protein breakdown, and of course leads to sarcopenia. This is taken from a case report. Very interesting to see here. This is a patient, elderly patient, who was given SGLT2 inhibitor, a diabetic patient. You can see the fat changes in the fat and the body composition here, and you can see the subcutaneous fat significantly reduced on day one. The visceral fat significantly reduced, in a few days. And you can see the muscle mass. I think this is day one of evaluation, actually, not day one of the thing. Patient was on treatment for a while. And the sarcopenia, there was also reduction in the muscle mass. So SGLT2 does lead to reduction in muscle mass. However, it also leads to reduction in the subcutaneous and visceral fat. So I think it has sort of a multi-pronged effect. When SGLT2 inhibitor was stopped, of course, there was a restoration of a lot of things, including the muscle mass. So, the criticism is perhaps not wrong that SGLT2 inhibitor lead to reduction of muscle mass. Now, SGLT2 inhibitors reduce fat more than muscles. So overall, if you see a sarcopenic obese patient, the patient may actually benefit because the fat reduces and the muscle mass often, also reduces, but the fat increases, it reduces more. So it's like, the classical debate of glass half full or half empty. The patient choice is, of course, very important. So how do you manage sarcopenia? Diet, exercise, vitamin D. These are the three main pillars. The diet, of course, you need to increase the protein content of the diet. And studies have shown that a protein intake of 1.2 to 1.6 gram per kg per day, that is a recommended daily intake, leads to improvement in the muscle mass. However, increasing it beyond 1.6 grams per kg does not lead to further increase in the lean mass. So this is, your standard protein intake, which is of course Indian patients don't take this much also, often leads to improvement. If you want to see the exercise, aerobic and anaerobic. Again, if you can see my virtual background, gym, right? Even your elderly patients need to go to the gym and increase their muscle mass. It's not just, just aerobic exercises. You have to do both. You have to do strength training also. Of course, make sure that your patient is not injured. Vitamin D intake, there is a interesting link between the bone and the muscle, and vitamin D has been, of all criticisms of vitamin D, I think this is one which I think probably is something which is a valid point. I think vitamin D does lead to increase of bones, increase of the muscle strength, and of course that should be considered in your vitamin D deficient patient. Vitamin D can be helpful to some extent. Of course, hormone replacement can always be considered, estrogen in women and testosterone in men. But this is an area of a lot of controversy and debate. And I think this controversy can be solved at a later date. So I'm not going to touch this. But of course, theoretically, hormone replacement definitely improves the outcome. You have, selective androgen receptor modulators or selective estrogen receptor modulators, which can have a positive impact. And perhaps changing diabetic medications, may have some impact. Especially in certain group of patients. So just to summarize some important take-home messages, the first and important take-home message is to diagnose sarcopenia. Like I said, it takes 30 seconds to do it. So please do it. It's very simple to do it. Just note it down in your prescription or in your letterhead. It's very simple in your notes. At least the patient understands this. At least you understand this, that you have done it. And I think this is a simple exercise to do. The other exercise that of course you need to do is to go to the gym. I'm saying this again and again. First you find the cases, assess them, confirm them, and check for the severity. The second important take-home message is that sarcopenia and obesity have a bidirectional link. Sarcopenia leads to obesity, obesity leads to sarcopenia, and of course similar bidirectional link with diabetes mellitus itself. The third important take-home message is that you need to understand that there are potential risk factors for sarcopenia. You need to look for them and correct them, and look closely perhaps at the role of SGLT2 inhibitor in relation to sarcopenia. Perhaps, like I said, this could be an important research question. And finally, proteins, vitamin D, and some amount of resistance training are important for treating sarcopenia. So I thank you again, and do a little bit of resistance training to your daily exercise routine, and you will be really well off. Thank you.